Kevin Osborne, Executive Director of the International AIDS Society.
Good morning, everybody, and welcome to day 2 of IAS 2019. I'm really proud to be talking about a segment that we're going to focus on for the next 15 minutes, which really looks at awards to recognize visionary, creative, and responsive programming to address what I think is one of the remaining challenges in the HIV response today. Stigma and discrimination, especially among key populations, still seems to be the Achilles heel, and we need to find ways to address that. And that's why I'm really pleased to say that the awards that you're going to see tonight, this evening, this morning, are going to be part of that approach to say, how can we do more to address stigma and discrimination for key populations? Sex workers in particular are often prosecuted and criminalized, and we need to find ways to address that. And so the awards today, you'll see, are trying to do just that. I'm really pleased to announce and introduce Deborah Waterhouse, CEO of ViiV Healthcare, and she will introduce the Positive Action Challenge Prizes. Please join me in welcoming Deborah.
Thanks, Kevin. I'm proud to be here today representing ViiV Healthcare at IAS 2019 to announce the award winners of this year's Positive Action Challenge, Sex, Work, Life and HIV, Stigma-Free Services for Sex Workers. Sex workers face many barriers in accessing comprehensive HIV treatment services, including stigma and discrimination from healthcare providers. This year's Positive Action Challenge specifically called for new and existing responses where sex worker communities and healthcare providers work together to provide stigma-free services. We were inundated with quality applications, a clear sign of the ongoing efforts to address this very real issue. To recognize the game-changing innovations and the incredible work already being done, exceptionally, this year, Positive Action Challenges has committed to awarding 3 seed prizes and 3 grand prizes. Today, we are proud to announce our awardees for the seed prizes to pilot brand new ideas. The Association of AIDS, Jazas from Serbia, Colectivo Ceres from Mexico, G3VN and consortium members from Vietnam are the winners. These 3 teams were unanimously recognized by our independent panel of judges for their novel ideas and strong commitment to collaboration between communities and healthcare providers. Please join me in congratulating and welcoming to the stage representatives from each of these organizations. First of all, Milos Stefanovic Rolic, Ernesto Ramirez Balderas, and unfortunately, Huang Taian from G3VN was unable to make it today, but we'll make sure that he gets his certificate. So Milos and Ernesto, could you please join me on the stage? Oh, you already know.
Thank you so much.
Thank you very much. So now it's my pleasure to announce the winners of the grand prizes awarded to expand an existing successful program. And the three winners are PACE from Canada, HOIMAS from Kenya, and Star from North Macedonia. These three teams showed an exemplary approach to tackling stigma. Their independent judging panel applauded the three programs for their inspirational work, improving sex workers' access to vital HIV services. We look forward to seeing the scale-up of these critical programs in their respective countries. So please give a warm welcome to Kit Rothschild, Pascal Machura Irungu, and Borche Bosniov.
Ladies and gentlemen, please welcome to the stage today's plenary co-chairs and speakers. To introduce our first plenary speaker, please welcome to the lectern the immediate past president of the International AIDS Society, Dr. Linda Gale Becker.
Well, good morning, everyone, and welcome to Tuesday morning's plenary. I'm hoping that you're all having fun at IAS 2019 in Mexico, and that already the program has set off many more ideas in your minds and ignited new enthusiasm to find solutions to challenges, to improve your care, understand the complexities, and generally get us closer to a world without HIV. I want to add my congratulations to Brenda and to Anton for a superb program and all the many people who helped to put this wonderful conference together. Our first plenary this morning, I think, will be of interest to everyone. There is no doubt that the interaction of the HIV virus with the human host is complex. This is on the background of an already complicated and diverse ecosystem known as the microbiome. Did you know that we have almost twice as many bacterial cells as human cells on our body, in fact, making up several pounds of body weight? And I'm not sure how you are about that, but I'm definitely claiming that in terms of my BMI. These form part of the microbiome and exist in all mucosal surfaces and body fluids. So you can imagine how important it is to understand the interaction between HIV infection and this already existing ecosystem, which is in itself affected by many different factors. To tell us more about this today, we are delighted to welcome Dr. Adam Bergener. Adam is head of proteomics at the National HIV and Retrovirology Labs at the Public Health Agency of Canada and an associate professor at the University of Manitoba. The focus of his research is to understand mucosal immunity and the microbiome and how these factors play a role in susceptibility, pathogenesis, and treatment of HIV. He has received New Investigator and Scientific Achievement Awards for his research from the CIHR, Canadian Association for HIV Research, and the Public Health Agency of Canada. This morning, because I think it's important for young investigators to understand motivation, I asked Adam what drew him to this important topic. And without hesitation, he named his mentor, Fred Plummer, who introduced him to the work in East Africa on sex workers. And he says, without doubt, that has ignited his deep passion for the subject. And I'm so excited to welcome him this morning to tell us more about what we should know about the microbiome and HIV.
That was a lovely introduction. Thank you very much. Happy to be here, and thank you for inviting me to speak today. So, just disclosure side, I have none. So what is the microbiome? I thought it would be nice to show a picture. What you're looking at here is the gut epithelium of a mouse. On the bottom in blue is the epithelial layer, in green is the mucosa, and on top you can see an incredible diversity of bacteria colored in red and purple and yellow. And when you stare at it, it really gives you an appreciation of how many microbes live within our bodies. So I'll give you some fun facts about the microbiome. What have we learned? Well, the microbiome is more than just bacteria. It includes viruses, fungi, genes, the metabolic byproducts, and proteins that live on all surfaces in our body. There are upwards of 10 times more bacterial cells than human cells, 100 to 1,000 times more bacterial genes than human genes. Over 1,000 unique taxa live within our guts. And as you heard earlier, it weighs as much as your liver. So it's not surprising to learn then that the microbiome is important for many things, including whether a heart medication will work for you, whether over-the-counter medication will be toxic to your system, whether or not mosquitoes like to bite you or not. And it's shaped very early in life, and whether you're born by vaginal birth or by C-section greatly shapes your microbiome early in life. So if you were to sequence your microbiome and look at the bacteria that are there, it would look something like this, which is something that's very complex with a lot of species living together happily in coexistence. And high diversity of the microbiome is often associated with increased health. In contrast, loss of diversity, as represented by this wheat field, is associated with poorer health. There are many things that can change the microbiome, including your diet, and while resilient to change, prolonged changes to the diet can impact microbiome diversity and function. It is also influenced by where you live, and many studies have linked living in urban and rural settings to gut microbial diversity. And microbiomes also being used for treatment, and one of the most successful stories is that of fecal microbiome transplantation, in which a healthy microbiome is taken from a healthy donor and given to a recipient with a disease-associated microbiome to restore mucosal health. And this has been shown to be extremely successful in the treatment of Clostridium difficile infection, which is not readily treated by antibiotics. So the microbiome interactions with disease have exploded in the past decade with advances in molecular tools to study the microbiome, including cancer and the therapeutic effectiveness of cancer therapies, the development of diabetes, as well as reproductive health outcomes, including the risk of preterm birth. And central to all of these diseases and conditions is this concept of microbial dysbiosis. And microbial dysbiosis, what this means is a qualitative or a quantitative change in the number of taxa, their distribution, or their metabolic function. And I will be talking about the gut and the vaginal microbiome today, as I do not have time to talk about microbiomes on every surface of the body. And dysbiosis in the gut, as well as the vagina, have been linked to many health outcomes, including those here: cervical cancer, preterm birth, the vaginal microbiome, cancer, diabetes, obesity, and the gut microbiome. And of course, increased HIV pathogenesis as well as transmission has been linked to dysbiosis at these sites. So I'll start by talking about the gut microbiome and HIV and what we know. So HIV-infected individuals, despite being on antiretroviral therapy, are at increased risk of morbidities and mortality, including risk of cardiovascular disease. And this is linked to chronic immune activation inflammation. And many soluble markers of inflammation as listed on the left, including IL-6 and soluble CD14, kynurenine to tryptophan ratio are predictive of morbidities and mortality in HIV. And a source of this chronic inflammation comes from the gut. So in HIV-infected individuals, there is a disruption of the gut epithelial barrier, as shown on the right, and these breaches and tight junctions allow microbial products to translocate into the system. And this is a source of chronic immune activation in HIV-infected individuals. And something that is very important for homeostasis of the gut is our microbiome. So our gut microbiome consists of these 4 major phyla: firmicutes, proteobacteria, actinobacteria, and Bacteroidetes. And they do many important things for our gut mucosa, including they help stimulate the production of mucins, which helps to clear bacteria. They digest dietary fiber and produce short-chain fatty acids, such as butyrate. And these act as chemical messengers to signal to reduce inflammation, as well as promote the stimulation and growth of immune cells that are very important for mucosal homeostasis. They also help to stimulate antimicrobial peptides, which are important for the clearance of pathogenic organisms. And finally, they also stimulate the production of mucosal antibodies, which also help clear bacteria. So the gut bacteria are very important for mucosal health. And in HIV-infected individuals, there have been many studies than those listed on the bottom left that have shown changes, compositional changes in HIV-infected individuals. And the most striking is that of an increase in proteobacteria and a decrease in firmicutes. And the most striking of this is an increase in Prevotella and a decrease in Bacteroides. However, later studies have shown that this increase in Prevotella is strongly linked to sex behaviors. And men who have sex with men have increased levels of Prevotella, as shown in various studies. And it's thought that this contributed to earlier observations of linkage with HIV risk, since this weren't controlled and sex behaviors were not controlled for in earlier studies. Nevertheless, there are many commonalities that have been seen in a lot of these studies, including an increase in D-cell Vibrio, Enterobacteriaceae, decrease of firmicutes such as Lactobacteriaceae, Ruminococcus, Clostridiales, and many other bacteria that are very difficult to pronounce. So what do these bacteria do? Well, they have many positive functions. Those that are depleted in HIV, such as Bacteroides, is important for production of short-chain fatty acids. Bifidobacteria, important for vitamins. Akkermansia is important for metabolism and a promotion of immune cells. Those that are increased in HIV, including Prevotella, Enterobacteriaceae, D-cell Vibrio, are often associated with pro-inflammatory functions. So it's likely that they're important or they're affecting mucosal inflammation. And certainly many of these bacteria have been linked to biomarkers of HIV disease progression, including increased IL-6, fatty acid binding protein, which is a marker of gut damage, T-cell activation, as well as increased neutrophil survival, which is thought to contribute to gut epithelial damage. In addition, a lot of these bacteria harbor genes that can metabolize metabolites that are important for immunity, including tryptophan. And it is thought that the bacteria are contributing to the kynurenine to tryptophan ratio that is observed and linked with HIV disease progression. Also, there's this concept that gene richness of the gut microbiome is important for gut health as it represents the stability, ecosystem stability of the gut microbiome. And when I talk about gene richness, what I mean is the total number of genes contained within the bacterial community. And in HIV-infected individuals, it has been observed in several independent studies that there is lower bacterial gene richness compared to HIV-uninfected individuals. And this is linked to lower nadir CD4 positive T cell counts. And interestingly, this is not reserved for just HIV, and bacterial gene richness is linked to many other gut diseases, including Crohn's, ulcerative colitis, IBS, and obesity. So dysbiosis in the gut is polyfunctional as well as polymicrobial. So is there anything we can do about it? Well, I don't have time to go through a lot of the trials, but there are lots of trials looking at dietary interventions, probiotics, prebiotics, fecal microbial transplantation, to restore dysbiosis in HIV. And while some of the results have yet to be released, early studies looking at probiotics, there's a clinical trial the ACTG is carrying out. There seems to be so far no linkage with reduction of inflammatory biomarkers, but this is still ongoing. There is some research showing that non-human primates, this does restore some positive function. Fecal microbiome transplantation, there was a study that tried this in HIV-infected individuals, but there was limited engraftment of the donor microbiome to the recipient, suggesting that dysbiosis in HIV is unique. It may need an alternate strategy. And there are other strategies to edit the microbiome, precision editing, such as enzyme inhibition, that could be future avenues of investigation. So now I'm going to move to the vagina, and this is an area of research that our lab is heavily engaged in. So the vagina also contains a microbiome that's very important for reproductive health. And the microbiome can be classified into two major groups. Women that have vaginal lactobacillus, including L. crispatus, lactobacillus iners, or Jensenii, that can vary in inflammatory properties, or women that do not have lactobacillus, instead of anaerobic or facultative anaerobic bacteria such as Gardnerella vaginalis, Atopobium, Prevotella, and others. And this is what's known as vaginal microbial dysbiosis, and this is associated with bacterial vaginosis. So it is important to realize that inflammation of the female genital tract is strongly linked with increased risk of acquiring HIV. This includes increased levels of pro-inflammatory cytokines, and it is thought that inflammation leads to barrier damage and increased recruitment of HIV target cells to the vaginal mucosa, making it easier for HIV to establish an infection. So the vaginal microbiome is very important for regulating inflammation responses and promoting mucosal homeostasis in the vagina, including lactobacillus produces lactic acid, which helps to keep inflammation low, as well as keep the pH slightly acidic. Lactobacillus is also associated with increased mucin production, as well as mucosal antibodies, and maintains homeostasis of the mucosal barrier. Whereas women with microbial dysbiosis, there is an increase in vaginal pH. This is associated with increased pro-inflammatory cytokines, production of short-chain fatty acids, which are very good for the gut, but in the vagina are pro-inflammatory. They also secrete a lot of enzymes that can degrade protective features of the vaginal mucosa, including mucins and mucosal antibodies. So it is not surprising to know that bacterial vaginosis is associated with increased risk of acquiring HIV. And with the advent of molecular tools, we're starting to get a better understanding of what these changes are and how they're linked to HIV acquisition. And so this study was from the FRESH cohort in South Africa, looking at young women who are high risk for HIV by Doug Kwan's group. And microbial or characterization of the vaginal microbiome is shown in the top in those colorful plots. Women had very diverse and different vaginal microbiomes, including group 1 that had L. crispatus as a dominant bacterium. In green, group 2 had Lactobacillus iners, 3 Gardnerella vaginalis, and 4 a polymicrobial profile with no dominant taxa. And importantly, women with these highly polymicrobial vaginal microbiome profiles that are highly diverse were at 4-fold increased risk of acquiring HIV compared to women with L. crispatus. And this is associated with increased levels of mucosal CD4 positive T cells, which are targets for HIV, as well as pro-inflammatory cytokines. Follow-up studies have quantitated the absolute abundance of bacteria in the vagina, and then linked many facultative anaerobic bacteria such as Gamella, Prevotella, Dialister, Megasphaera with increased odds of acquiring HIV, whereas L. crispatus and L. iners were associated with reduced HIV infection. So we're starting to get a picture of a lot of bacteria that are linked with HIV infection risk. And not only that, the vaginal microbiome is also associated with the efficacy of HIV prevention modalities. And we did a study in collaboration with Capriza and Nikki Klaas' lab at the University of Washington, and looking at women for the Capriza 004 trial, which tested a vaginal microbicide containing tenofovir for HIV protection. And interestingly, women who had vaginal lactobacillus, the drug worked three times better than women that did not have vaginal lactobacillus and instead had anaerobic or facultative anaerobic bacteria. And many of these bacteria in non-lactobacillus dominant women could metabolize tenofovir as well as reduce the activation kinetics of the drug. However, follow-up studies looked at the interaction between the vaginal microbiome and oral PrEP, and there was no association between efficacy of oral PrEP and the vaginal microbiome, indicating that the microbiome may only be relevant for topical strategies or only for certain drugs in topical prevention strategies. So HIV infection in young women is still a major problem. There are over 400,000 new infections in sub-Saharan Africa of young women. And many studies of the vaginal microbiome have shown high levels of microbial dysbiosis in many of these countries of high risk, as shown on the right. So on the right, these pie charts, I did a summary from various studies, and in purple are women that have vaginal microbial dysbiosis. And you can see that pie chart, there's a large amount of women in purple, indicating large levels of dysbiosis, which suggests that the promotion of vaginal lactobacillus may be an important prevention strategy to lower HIV transmission. So what can we do about vaginal microbial dysbiosis? Well, the treatment strategies for this are not very good, and we have very old methods, including antibiotics, metronidazole or clindamycin, which can be effective initially, but there's a high recurrence rate associated with this treatment. There are probiotic strategies that are being employed either as adjunctive or replacements to antibiotics, and this has shown some success in improving outcomes and durability of this treatment. But importantly, these treatments do not necessarily resolve vaginal inflammation, suggesting that just changing the bacterial taxa are not enough to, may not be enough to reduce inflammation associated with HIV transmission risk. So with this in mind, we need to move beyond compositional characterization of the microbiome, and there are many techniques that can look at composition, including targeted sequencing of the 16S ribosome RNA gene. This gives you composition, but it doesn't tell you anything about the function of the bacteria. And there are many techniques that can give you some more functional information, including shotgun sequencing, the entire DNA of the microbial communities, the transcriptome, metatranscriptome, looking at the genes are activated, looking at the proteome, and these are the translated protein products of the bacteria, as well as the metabolome. And as we move down, each one of these methods I can make an entire seminar on, and I won't discuss them in any detail, but basically as we move down to these advanced omics techniques, we get more functional information, we get to understand what the bacteria are doing, not just which ones are there. And our lab is interested in, we develop these later techniques to study the microbiome, and we want to understand what functional products of the bacteria are important for inflammation of the genital tract as well as acquisition risk, and can we use these to select for bacterial species that might be good probiotic candidates or for interventions. And this is not a far-fetched idea. In the gut, Akkermansia muciniphila is being used to treat metabolic disorders, and an outer membrane protein found on bacteria, Akkermansia, it has many immunomodulatory properties. So these factors are very important for, can be potential treatment options. So we have partnered with leadership in the HIV field, including those that have led groundbreaking HIV prevention trials, including Connie Seelam, Jared Baton, Nelly Mugo, and Jay Langappa from the Partners PrEP trial, Sharon Hillier, Jeannie Morazzo, Mike Turinge from the VOICE trial, as well as leadership at Capriza, Salim Karim, and Karisha Karim, and Lyle McKinnon. And with their generous support and access to mucosal specimens from these trials, we've been studying HIV transmission. So this is a compositional plot of the vaginal microbiome as seen by proteomics techniques. And this is on over 1,600 women from these prevention trials, as well as other studies that we're doing. And what you can see is there's a large range. Each dot represents a single sample from a single woman, and the distance between the dots represents how different compositionally they are from one another. And we've put some colors on them to help illustrate these differences, including those in yellow have Lactobacillus crispatus as a dominant organism. Those in the bottom right have Lactobacillus inners. Bottom left, G. vaginalis is a dominant bacterium, and those in red are women that have no dominant taxa and are said a highly polymicrobial. And you can see there's a great diversity of composition of the vaginal microbiome. And if we plot it functionally, we see something different. So this is plotting the bacteria at the metabolic pathway level, and you can see it comes out to a big smear. And showing there's a lot of functional diversity between these microbiome types. If we overlay the composition of the microbiome and the presence of lactobacillus as shown in orange or brown, you can see that some of this variation in the function is associated with composition, but it's not complete. There's a large overlap in the middle between microbiomes that have completely different bacterial taxa, but very similar functional profiles. If we overlay a specific pathway, such as glycolysis, we can see on the right those microbiomes that have activated glycolysis compared to ones on the left that do not have this pathway. And you can see this does not relate at all to the composition of the microbiome, indicating that function can be independent of composition, whereas some functions, such as ABC transporters, are associated with composition of the microbiome. So we're interested in looking how this relates to inflammation, and using proteomics techniques of vaginal mucosa, we can map a lot of inflammation pathways in the female genital tract. So on the left there are a lot of inflammation pathways, which I won't go over, and the relationship to microbiome composition is shown in the dots. So women that have G. vaginalis or polymicrobial microbiome types have an increased activation of a lot of inflammation pathways, such as IL-8, IL-6, acute phase response signaling, in comparison to women that have L. crispatus. But interestingly, in some cases, we can take some of these inflammation pathways and describe them better by the metabolic pathways of the bacteria rather than the composition, as shown in the plots on the right. So not all women that have bacterial vaginosis have genital inflammation. And so we're trying to understand why that is. So we looked at 2 different cohorts, including Voice and Caprisa 004, women that did not have vaginal lactobacillus. And we're looking at functional pathways related to inflammation. And we looked at carbohydrate metabolism as an example. And women that had carbohydrate metabolism active in the microbiome, as shown in the green bars over top the heat maps, in comparison to women that did not have carbohydrate metabolism in yellow. And as you can see, this having carbohydrate metabolism active was associated with reduced inflammation as well as increased pathways associated with epithelial barrier function. And interestingly, if we look at the inflammation differences and we separate it by this metabolic pathway, on the right, in red, we can see larger changes associated with bacterial carbohydrate metabolism than we do with comparing women with L. crispatus compared to having a polymicrobial profile with a lot of anaerobes, which indicates that not only composition, but metabolism may be related to inflammation or is more important for inflammation. So we've been looking at how bacterial proteins and metabolism rates to HIV acquisition risk, and this is very preliminary data, and we're still investigating all of these pathways, but we do find that proteins and enzymes related to non-lactobacillus bacteria involved in carbohydrate metabolism associated with increased HIV production, as shown in the left. And any women that have any 3 of these enzymes in the upper interquartile range are at 5-fold lower risk than women that do not have these enzymes, indicating a relationship between bacterial metabolism and HIV infection risk. And we did not find any associations with contraceptive usage or age or study arm or sex behaviors that could explain these differences. And interestingly, these bacterial enzymes are not reserved for any specific bacterial species and are said belong to multiple species such as Gardnerella, Prevotella, Rhumacoccus, and Mobiluncus. So in order to understand how these things function and are relevant for mucosal immunity, we use in vitro models as well as in vivo models to test them. And this is work done by Dr. Alicia Berard, who develops differentiated vaginal epithelial cell models, and she co-cultures them with products from BV-associated bacteria as well as lactobacillus. And in the plot here, you can see that there's a separation of molecular pathways associated with Mobiluncus or Prevotella or G. vaginalis in comparison to L. crispatus. And these belong to many epithelial barrier functions as well as inflammation. In addition, we're looking at how dysbiotic bacteria associated vaginal immunity in mice, and doing intravaginal inoculation. This is work with Thomas Maruka, University of Manitoba, as well as Christina Farr, a postdoc in my lab. And we can do vaginal molecular profiling after seeding with bacteria or bacterial products, and we can see with saline or L. crispatus, there's minimal, if any, inflammation effects, but with Mobiluncus, a BV-associated bacterium, we see strong effects on increasing innate immunity as well as cell-to-cell adhesion pathways. And we're using these models to see how these functional products in bacteria relate to genital inflammation. Beyond that, we're also looking at what is important for stability of these pathways and how do they relate to diet and other features. So we're enrolling women in the THRIVE study, and this is in Canada, where we're looking at the functional changes over time daily in women. And this is just this red dot here shows the daily variation of the function of a woman with very high variability. And you can see it bounces all over the place in comparison to women that have very low functional variability. And we want to understand what is important for durability and stability of the microbiome, and we hope that this could be useful for interventions. So in summary, an imbalanced microbiome underlies both increased HIV pathogenesis and HIV transmission. Microbial dysbiosis is polymicrobial, but also polyfunctional. So future translational research to resolve dysbiosis is a reasonable goal to improve health outcomes of those who are living with HIV, as well as those who are at risk of HIV infection. But we think that reaching this goal will require further investment to understand the functional products of the bacteria and how they relate to mucosal health and HIV disease. And with that, I would just like to do a plug-in for a microbiome session that's occurring at 1 o'clock today. Mucosal tissues, what's Krobes got to do with it? I didn't come up with that name, but I think it's very catchy. Where our group is showing an interaction between the vaginal microbiome, inflammation, and inflammation associated with hormonal contraceptives, including DMPA, and how this relates to HIV infection risk. And I think this is a very important topic. Also, a presentation by Heather Jaspin and Renee Heffron showing how the vaginal microbiome and inflammatory features change within the participants of the ECHO trial. And Rafil Wei, who is presenting a presentation on inflammatory cytokines, how this relates to the microbiome, as well as contraceptive usage. So this should make a very engaging discussion, and I hope everyone comes and attends. So with that, I would like to thank all of the students in my lab and research scientists, including Laura, Alicia, Michelle, Lana, Hosanna, Sarah, and Kenzie, who did a bulk of the work here that I presented today, as well as my clinical collaborators, that without their support I wouldn't be able to do this research, in University of Manitoba, as well as, most importantly, the study participants, including those in the Thrive study, Capriza, Voice, Partners Prep, and their engagement in these studies is really critical to help us understand HIV transmission, and I thank them very much for participating and providing samples. And thank you very much.
Well, I don't know about you, but I have an overwhelming sense of watch this space. And I have no doubt that Adam is going to continue to make huge contributions and help us understand this. So thank you so much for that plenary. Well, we've heard much about the 90-90-90 goals. And if you had been at the HIV control symposium yesterday evening, you will have been reminded that we will need to pay attention to finding the hardly reached and ensuring that they receive testing, treatment, and the kind of quality care that enable people to stay in our services for their lives. This means we also need to think about the fourth 90, as Francois Dabi referred to it yesterday, or the quality of care 90. At the IAS, we call this patient-centered care or differentiated service delivery. I know that our next speaker has spent many, many hours thinking about this. But more than that, she's actually got into the field and continues to go back to the field, really looking to have the best models and the best practices. In similar vein, when I asked Ingrid what made her do the work she does, she mentioned that she is the daughter of a Peruvian mother, and as such, she has traveled the world and had many experiences. So to young investigators, I say, get out there and see the world, because I think this frames how we think. I will say, though, knowing Ingrid, there is a second factor, and that is her huge compassion for humanity, which I think drives a lot of her work. Ingrid Bassett is an associate professor of medicine at Harvard Medical School and an infectious diseases physician at Massachusetts General Hospital in Boston. She's the director of the developmental core and of mentoring programs at the Harvard Center for AIDS Research. She has over 15 years of experience leading clinical research in South Africa. I'm pleased some of it with us, much of it in KwaZulu-Natal, on HIV, TB screening and treatment, with a recent focus on community-based interventions. She was the winner of the 2015 HIV Medicine Association Research Award. Ingrid will deliver a plenary entitled Barriers to Access to Diagnosis and Treatment, and I can't think of anyone better to do it. It's my pleasure to welcome Ingrid to the podium.
Buenos días, todos. Thank you very much. I'm really delighted to be here today. I'm going to be speaking about global progress towards HIV testing and linkage to care goals, the first two 90s. Then I'm going to talk about barriers to progress and their impact on HIV testing and linkage. I'll show some examples of recent novel testing approaches to try to overcome these barriers, and then some novel linkage solutions, and finally some conclusions and thoughts about what's next for areas that need more work. The talk today will focus on the UNAIDS targets for HIV testing, having 90% of people living with HIV knowing their HIV status, the first 90, and on linkage to care and initiating ART, the second 90. Reaching these targets is achievable, and in some settings we've seen examples. Here's the example of Botswana from a generalized HIV epidemic, and here's Australia from a concentrated HIV epidemic. While these goals may be achievable, most countries in the world fall well short of the targets. Globally, it's estimated that 79% of people living with HIV know their status, and 78% of those are on ART. I will not be speaking today about the third 90, as Dr. Maimela spoke eloquently about that in yesterday's plenary. I will, however, be talking about the fact that these steps are nonlinear, such that people on ART may leave care and then return again and reinitiate treatment. Though I'm not talking about prevention today, I'd also like to mention the importance for people found to have a negative HIV status to link to HIV prevention services. With the 79% of people knowing their status, how do we go about finding that last 20% or so of people living with HIV who don't know their status? What are the barriers to finding those people and getting them into care? Now I'm going to talk about some of these barriers that span both HIV testing and linkage. This includes patient populations that have multiple barriers and require more innovative approaches. The first population that I want to highlight is men. Men are less likely than women to test and initiate and adhere to ART. In almost all regions of the world, women, shown in red in this figure, are more likely to be on ART than compared to men, shown in blue. This is true in generalized epidemics, such as in Eastern and Southern Africa, and in more concentrated epidemics, such as in Eastern Europe and Central Asia. And this translates into increased mortality for men worldwide. Men experience a number of barriers, including social norms about masculinity, opportunity costs for missing work, and anticipated stigma and loss of social standing if diagnosed with HIV. Another group with barriers is adolescents. Here is the proportion of people diagnosed, receiving care, and retained in care by age group in the US. Here in the dark purple, we see that adolescents aged 13 to 24 are the lowest of all the age groups. This is the experience with adolescents globally. Some of the most common psychological barriers to HIV testing among adolescents are lack of perceived risk and worries about rejection. There are also structural barriers to HIV testing and linkage, including never being offered an HIV test, inconvenient clinic hours and structure, and parental consent laws. The majority of countries have parental consent laws for people under the age of 18 for accessing sexual and reproductive health services that include HIV testing and treatment. These laws may be especially detrimental for young men who have sex with men in the United States and young women in sub-Saharan Africa who each bear a disproportionate burden of new HIV infections. Turning to key populations, we know that key populations are at higher risk for HIV and that more than half of new infections globally in 2018 were among key populations and their sexual partners. Though they are at higher risk, their access to treatment tends to lag behind the general population. Here is an example showing different countries throughout the world with the proportion of people accessing ART. The blue dots representing the general coverage in the general adult population, and the red bars representing treatment coverage for female sex workers. Almost uniformly, female sex workers are less likely than the general population to be accessing ART. This is often true for other key populations as well, including men who have sex with men, trans women, and people who inject drugs. A major barrier for people seeking care is unfortunately stigma and discrimination in the healthcare system itself. This figure shows in orange the proportion of people living with HIV in a selection of countries from different world regions who say a healthcare provider told other people about their HIV status without their consent. And in blue, the proportion who said they were denied health services because of their HIV status. You can see the world over that people living with HIV experience stigma and discrimination and feel unwelcome in healthcare settings. This can clearly influence the first two 90s. While it may be difficult for us as the healthcare community to change society at large, we need to increase our efforts to make sure that people feel welcome to seek care in our healthcare systems. Laws can also affect how people behave. This is a figure looking at the effect of a same-sex marriage prohibition law in Nigeria, surveying men who have sex with men before and after passage of the law. You can see that compared to the pre-law period in light purple, during the post-law period in dark purple, men who have sex with men were more fearful of seeking health care and felt more persecuted. We as a medical community should be lobbying to overturn laws that criminalize sexual behaviors that affect people's willingness to know their HIV status and link to care. We have seen some progress on this front, including this recent article from The Economist, highlighting that Botswana recently legalized gay sex. But according to UNAIDS 2019 data, 67 countries criminalize same-sex activity, mainly in Africa, the Middle East, and Russia. I want to end the barriers section with showing how these barriers to care have effects on outcomes for patients. This was a study that we did in South Africa looking at self-reported barriers to care at the time of HIV testing in categories like service delivery or financial barriers. We found that nearly a quarter of people reported more than 3 barriers. By 1 year, 13% of participants had died. Even when controlling for known risk factors for death, like CD4 count and TB, people reporting more than 3 barriers to care were nearly twice as likely to die by 12 months compared to those with no barriers. This relationship remained true over 5 years of follow-up. So people can tell us that they're experiencing barriers to healthcare which can predict poor outcomes and which need to be intervention targets. Turning to interventions, I'm now going to transition from barriers to testing and linkage to talking about HIV testing innovations that attempt to overcome some of these barriers and appeal to populations who are less likely to know their HIV status. Testing people for HIV at health facilities has been a critical part of efforts to increase HIV knowledge and awareness. But what about people who don't come to facilities? We know that community-based testing reaches some groups better than testing in facilities. Community testing includes testing outside of health facilities, like being tested at home by a counselor, self-testing, mobile testing at community venues, and testing in health campaigns. In a meta-analysis, men, young adults, and first-time testers were more likely to be reached by community-based HIV testing than facility testing. Community-based testing overcomes some of the structural barriers of deciding to attend a clinic, transport, distance, and also may overcome stigma by normalizing testing. Let's look at some of these community testing methods in more detail. This is a study that we did about mobile HIV testing in Durban, South Africa, in Umlazi Township, outlined in gray on the map, comparing mobile testers tested at community venues like markets and taxi stands to clinic testers. We found that mobile testers were younger, more likely to be male, to have higher CD4 counts, and to have tested further from home than those tested at clinic. Mobile testing can help identify where in the community we should be looking for these harder to reach populations. You can see on the map the circles representing testing locations with a range of HIV prevalences. We found that commercial zones and transport hubs had the highest yield for finding new cases. Mobile testing may overcome some structural barriers and stigma related to clinic visits. We'll come back to mobile testing later when we talk about linkage strategies. Another area of great interest is HIV self-testing. This is a way of empowering people by allowing them to perform their own HIV test. The STAR initiative in Malawi, Zambia, and Zimbabwe really spurred the WHO to recommend HIV self-testing in its 2016 guidance. STAR distributed over 600,000 OraQuick HIV self-test kits, mainly through community venues. They were able to reach men, people aged 16 to 24, and first-time testers better than we traditionally do in healthcare facilities. The HIV prevalence was lower among self-testers than those tested in facilities, but still substantial. This method may appeal to lower-risk individuals. It could be useful for national testing campaigns, catch-up campaigns for area with low testing coverage, or for people that may need frequent testing but are not willing to come to health facilities. One way of reaching people is through their social network. This is a study of Blued, the largest gay dating and social networking app in the world, with 40 million users, mainly in China. Blued launched an HIV testing campaign that included a one-time mass message push notification, banner ads, and an embedded HIV testing appointment platform. After the campaign launched in March 2015, as shown by the purple line, HIV testing volume increased dramatically at the 6 Blued drop-in centers in Beijing, with an HIV prevalence about 5%. So this is a way of finding a more hidden population by using a social media app that they have already embraced. This idea has been extended by others to incorporating key populations for distributing HIV self-test kits to their own social network as a way of overcoming stigma and medical mistrust. The final testing method that I want to touch on is assisted partner notification. Despite some initial concerns, this does appear to be an acceptable method. In this model, people newly diagnosed with HIV, like the yellow man in the middle of the circle, identify their contacts, be they sexual contacts, injection partners, or biologic children. And then the person is assisted in offering HIV testing to those contacts. In a systematic review done by the WHO, they found that compared to passive referral, with assisted partner notification, there was an increase in the uptake of HIV testing, an increase in partners found to be HIV infected, and also an increase in linkage to care for partners. Assisted partner notification may be particularly helpful in countries with low HIV testing coverage, where partners are less likely to undergo facility-based or other community testing. While few instances of violence or harm were seen in this review, many studies exclude women with a recent history of intimate partner violence. So social harms will need to be monitored as this practice becomes more widespread. Now I'm going to turn to strategies to improve linkage to HIV care that attempt to overcome barriers to linkage and appeal to the harder to reach populations. I think one of the important tensions here is that while community-based HIV testing can be very appealing to people, and it can also create an extra burden to actually be able to link people to care that may be based in a facility. This figure from a meta-analysis examining home and campaign-based testing found only 26% of those newly diagnosed with HIV in home and community campaigns visited an ART clinic, compared to 61% with facility-based testing. The exception to that is in the middle circle, which was home and campaign testing combined with facilitated linkage interventions, which had a high rate of linkage. So while community methods for testing are appealing and may reach people that are otherwise difficult to reach, facilitated linkage strategies are needed to ensure that this testing leads to linkage to care and ART initiation. So what are some linkage strategies? In San Francisco, they've taken a real systems-wide approach in their Getting to Zero initiative. This is a rapid ART program where they have created HIV testing hubs with community partners around the city, where people newly diagnosed or out of care get expedited ART initiation and linkage to medical homes. Using linkage navigators and standardized operating procedures throughout the city, they were able to shorten the number of days from diagnosis to first visit from 8 to 4 days, and from first visit to Art Start from 27 to 0 days between 2013 and 2017. This has resulted in a decline in new HIV diagnoses in San Francisco over the same period. This strategy may overcome structural and financial barriers as well as healthcare-related stigma. We've also seen good results with same-day testing and ART initiation in clinic-based studies in Haiti and South Africa. What about initiating ART in an expedited fashion at home? The Cascade trial was the first trial to assess same-day ART initiation outside of a healthcare facility. In this study, people testing at home in rural Lesotho were randomized to either same-day ART initiation at home by a trained team of nurse and lay counselors, or usual care, which involved referral to healthcare facilities after home testing. When they looked at their primary outcome, same-day ART initiators were more likely to have linked to care at 90 days, 69% in the same-day group versus 43%, suggesting that starting ART at home and helping people make the transition to ongoing ART care in facilities is promising. Initiating ART outside of clinic has applications for key populations as well. This is a study in female sex workers who we know have high barriers to care in facilities, in which they went beyond not only initiating ART outside of the healthcare facility, but providing ongoing ART care for female sex workers in the community. This was a study in Tanzania where community-based teams offered mobile and home HIV testing to female sex workers. In the intervention district, participants were also offered ART on an ongoing basis at a convenient community location of their choice, compared to the comparison district where people were referred to healthcare facilities. When they looked at linkage to care, ART interruptions, and rates of internalized stigma, all of these were significantly better in people in the intervention district in comparison to the control district, suggesting that community-based ART initiation and ongoing ART dispensing for key populations may be a strategy for overcoming stigma and giving key populations more autonomy. What about linkage after self-testing? There's a lot of concern about people testing at home and whether they will still link to facilities. This is a study of linkage after self-testing for male partners of women in antenatal clinic in Malawi using incentives. Women were enrolled in antenatal clinic and randomized to standard of care, which included a letter inviting partners to test, or one of 5 intervention arms, all with 2 HIV self-test kits for partners. Either self-test kits alone, self-test kits plus varying financial incentives, or self-test kits with phone call reminders. The primary outcome was the proportion of male partners with evidence of testing and linkage to care or prevention within 28 days. Overall, only about 29% of male partners had tested and were linked to treatment or prevention. However, rates of linkage after self-testing with the $3 and $10 incentives and self-testing with a reminder were statistically significantly increased compared to the standard of care, with self-testing plus the $10 incentive group having about 52% linkage. This study suggests that for men, incentives may be useful for helping them stay in the care cascade. Incentives may help provide tangible benefits for testing and linkage and offset some of the real costs associated with missing work. But I would say overall in the literature that financial incentive evidence has been mixed, and we need to know more about how best to structure these for maximum benefit. While there are many studies related to HIV testing strategies for adolescents, there are very few studies about linkage to care strategies for adolescents. This was a notable exception of a pilot program in Homa Bay, Kenya, in which they tried to address this issue at multiple levels, with components at boarding schools, health facilities, and in the community through peer services. What's remarkable about this was that youth and adolescents were involved in designing and monitoring the intervention, which includes, for example, VIP adolescent-friendly express services in clinics so that youth would not have to wait. In a pre- and post-intervention design, linkage to care, ART initiation, and the proportion of youth retained in care at 3 months increased significantly. This is promising, but linkage to care for adolescents is an area that still needs a lot of work. I want to change to talking about a policy shift which is important for linkage to care as it relates to the WHO recommendations to treat all people regardless of CD4 count. thus condensing the pre-treatment phase of the care cascade. Some studies performed under treat-all conditions have had disappointing rates of linkage to care. Barriers to linkage to care in these trials have included inconvenient clinic hours, overcrowded clinics, health provider attitudes, stigma, and shame. While this policy is the right one from an individual and public health perspective, in some sense it creates a new challenge. People that are feeling well who may not see the value of getting into care quickly. I'll highlight just one study which tried to overcome barriers to treat all. That was the SEARCH trial, a community cluster randomized trial in Kenya and Uganda. They combined really two different ideas with universal art to address some of these structural, behavioral, and health systems barriers. One was integrated health screenings, including hypertension, diabetes, cervical cancer, and others, plus HIV screening in mobile community health campaigns and in home-based testing for those not reached in the campaigns. This integration may help destigmatize HIV testing and resulted in 90% of residents undergoing HIV testing in the trial. The second aspect of this intervention was patient-centered linkage components. This included being immediately introduced to a clinic staff following an HIV-positive test, flexible clinic hours, appointments with reminders, transport reimbursement, as well as providing a hotline where people could contact providers for questions or support. This trial had high rates of linkage to care, with 83% of people in the intervention group not on ART at baseline starting treatment by 3 years, as shown in blue, compared to 50% in the control group who were treated under national guidelines under usual care conditions. Integration and patient-centered services may be important for the treat-all policy to be effective. Integration of other health services that may be important to the person with their HIV services also shows promise in other settings. This is an example of integration of services for substance use and HIV. This randomized trial used a strengths-based case management intervention for people hospitalized in Russia for substance use, led by peers, people living with HIV with a history of injection drug use. This trial shows some promise in that those in the intervention arm were more likely to link to care compared to the control arm, but there was no difference in CD4 count at 12 months, and overall entry into care was low. I think this speaks to the silos of addiction care and HIV care in this setting. Many of the interventions that I've described focus on men. What about women at high risk? I really wanted to have a slide about linkage to care following integration of HIV services with family planning services. And while there are many studies looking at HIV testing among family planning clients, and this seems a promising approach, a systematic review published this year showed there were no studies that measured linkage to HIV care and treatment following integration of HIV testing into family planning services. In certain settings, like sub-Saharan Africa, young women are at extremely high risk for unintended pregnancies, HIV, and sexually transmitted infections. Therefore, studies that look at the integration of HIV testing and linkage services into family planning are critical as we move forward toward the testing and linkage goals. Most of the people that we've been talking about thus far are people entering care through the front door, people undergoing HIV testing and initiating treatment. What about people who've been in care and have then dropped out of care and are now reinitiating or entering through the side door? These people are of increasing import in mature ART programs. For example, these are data from the Western Cape province of South Africa, which has a well-developed public sector HIV program. This is an annual cross-sectional snapshot of the proportion of people with a CD4 count of less than 50 based on their past history of ART exposure. You can see in the red bars that people attending HIV care for the first time initially constituted the largest proportion of people with CD4 counts less than 50, and this dropped over time from 60 to 21%. By contrast, the proportion of people in purple who were previously on ART and are now coming back with CD4 counts less than 50 has increased dramatically over that time from 14 to 57%. This high priority group will continue to grow as treat-all expands, more people living with HIV initiate ART, disengage from care, and then need to be re-engaged. A recent systematic review found no published studies specifically focused on people living with HIV who had fallen out of HIV care or were previously on ART. Here, I highlight a pilot program from Médecins Sans Frontières in Kailicha that is trying to encourage re-engagement through their welcome service. At one of their clinics, they're actively tracing people through clinic files who have dropped out of care, and are also trying to attract people through WhatsApp and Facebook to invite disengaged people back into care. They're offering psychosocial support and peer navigation with an emphasis on normalizing disengagement and empathizing so people feel welcome to come back into care. This is still in the pilot phase, but I think a very promising approach. Turning to the conclusions and what's next. We need to actively pursue hard-to-reach populations, including males, adolescents, key populations, and those in rural areas to reach the 90-90-90 targets. Testing people where they are, be that at home, through mobile HIV testing, HIV self-testing, through social media, seems particularly promising. We should provide choices for linkage to care and ART delivery that are patient-centered and flexible. These can be at facilities, but also at home, school, or community sites. HIV services should be integrated with other key health services like non-communicable disease treatment, substance use, and family planning. And we should make efforts to welcome back those previously in care. So my closing thought is that no one should be diagnosed late or die of HIV in the setting of rapid HIV testing and well-tolerated, widely available ART. We need to redouble our efforts to close the gaps in HIV care. I'd like to thank my colleagues in the US and South Africa, the IAS for inviting me, and the funders who support my research. Thank you.
To introduce our final plenary speaker, please welcome to the lectern the World Health Organization Assistant Director General, Dr. Ren Mingui.
Good morning, ladies and gentlemen. Thank you, Linda Gale, and also thanks to our two previous speakers. It's always so exciting to hear the pioneer researchers presenting their work, ranging from biomedicine, public health, and social policies. Before I introduce today's final plenary speaker, who will present on key populations in Latin American region, I would like to take a few minutes to offer some thought on how universal health coverage provides important political and programmatic opportunity to reach the key populations around the world with health services they need. At the heart of the World Health Organization's current 5-year strategy is a commitment to support countries to achieve health-related sustainable development goals. In that strategy, we, WHO secretaries and member states, have set a target in which 1 billion more people benefit from universal health coverage by 2023. Universal health coverage means that all people access to health service they need without suffering financial hardship. Universal health coverage means nobody is left behind. It serves all people, whether they are people who use the drugs, sex workers, prisoners, transgender people, or men who have sex with men. All it serves people wherever they live, from remote communities to urbanized slums. Universal health coverage means that the health services provided are of high quality, evidence-based, and achieve impact. And health finance in the countries should cover for those populations most vulnerable, marginalized, and at risk. Universal health coverage must address full range of HIV prevention, treatment, and care needs alongside the broad health needs, including those related to sexual reproductive health, tuberculosis, viral hepatitis, chronic non-communicable diseases, mental health, and other comorbidities. In our conversations about the universal health coverage, we must continue to address the importance of multi-sectoral action to address the drivers of HIV epidemics, such as gender-based violence, criminalizations of key populations, female genital mutilation, and child marriage. WHO and the partners across the UN systems will continue to work together alongside the governments to challenge and change the social, gender, and cultural norms that stand in the ways of the health. Even as we strive to apply the learning from HIV/AIDS to a broad health, we have to recognize that is, according to the UNAIDS data shared last week, key populations and their sexual partners account for more than half of new HIV infections globally. That is 54% of new infections of HIV. In 2 months' time, the heads of states will gather in New York for the United Nations General Assembly, a high-level meeting on universal health coverage, moving towards to the healthy world. This high-level meeting will be their last chance before the 2023, the midpoint of implementation of 2030 agenda for the sustainable development, to express the highest levels of political support for sustained investment in health. While there's impressive progress towards robust political declarations, the outcomes documents from high-level meeting, we cannot be complacent as challenges remain and the public support for issues of social justice cannot be taken for granted. The high-level meetings offers the platforms to reaffirm the political mandate, not just to improve the SDGs' health outcomes, but to transform enabling environments and health systems on which billions of people, including key populations, depend. And as we take our message to the high-level meetings about extending learning from HIV to broad health, we have to remind the government that is, we are still feeling the key populations in HIVs and the broad health efforts. We have learned from HIV/AIDS that the universal health coverage will not be achieved when the people are marginalized, criminalized, stigmatized, or denied access to health services for any reason. This has to be the HIV community's key message to the political leaders gathering in New York in September. Universal health coverage requires bold political commitment, together with thoughtful strengthening of health programs and systems that keeps the people, all peoples, at the center of the decision-making process. On that note, I would like now to turn over to our final, but of course, last but not least, our speaker for this session, Carlos Casares, is well known to many of us with an impressive career in HIV's related work spanning several decades. Carlos is professor of public health and director of the Center for Interdisciplinary Studies in HIV, AIDS, and Society in Colorado Heritage University in Lima, Peru. He is also the director of Institute Studies in Health, Sexualities, and Human Development. He attained his MD degrees from the university and his University of Kenya Heritage University, and his MPH and PhD from the University of California, Berkeley. For more than 20 years, Carlos has led numerous studies on HIV and sexual health with populations of men who have sex with men, transgender women, and people living with HIV. Currently, he is the principal investigator for the Peru's IMPREP, the demonstration project for the PrEP's implementation in the public health systems of Brazil, Mexico, and Peru. The Carlos has conducted intensive research on health policy and systems, focusing on the global health and the national research to HIV/AIDS, as well as the structured determinants of HIV epidemics. Apart from his research experience, he also served as consultant to various UN bodies for diverse planning, research, and training activities. He coordinated the network of multidisciplinary studies in HIV-based HIV prevention. He was founder and past president of International Association of Study for Sexuality, Culture, and Society, and was a member of the Strategic and Technical Review Panel for WHO Headquarters and PAHO, as well as the IAS Governing Council and the Global Fund Technical Review Panel. Today, Carlos will be speaking to the theme, Key Populations in Latin America, Young Men Who Have Sex with Men. Please join me in welcoming Professor Carlos Saras to stage. Thank you.
Buenos días con todas y todos. It's an honor for me to be here in Mexico City today. I'm pleased to acknowledge the valuable support of many friends and colleagues. Talking about young MSM in Latin America, today I plan to cover definitions, epidemiologic data, sexual risks and access issues, as well as their social determinants, and a few intervention models studied in the region to conclude with some take-home messages. But let's start acknowledging that we're talking about human beings. For example, let's meet Jorge. A 23-year-old employee, Jorge got HIV from a boyfriend he had been going out with for a few months. Upon his diagnosis, he started free treatment through the Mexican Institute of Social Security. He had excellent adherence to ART and remained undetectable until 3 months ago when he had to stop treatment temporarily due to a shortage of ARTs. He has also developed anal warts and has been waiting for surgery for months since he can't pay for the procedure elsewhere. He feels that his doctor does not treat him very well, perhaps due to his sexual orientation. Let's keep in mind this personal story while we move on. So, there are various overlapping technical definitions related to young people. Here we're focusing on young men 15 to 24, recognizing that they comprise two groups, those 15 to 17 who are legally minors with restricted rights, and those 18 to 24 who are, say, emerging adults. As this goes beyond identity, we say young gay and other men who have sex with men, recognizing that there are issues about age of consent to consider. Then, given the data available, I will focus mostly on Spanish and Portuguese-speaking individuals. Of course, trans women are a distinct population not covered in this talk. Let's move to some epidemiologic data. For your information, many of my points will be illustrated by data from the following sources. First, the Latin American MSM Internet Survey, LAMIS, with online responses from around 65,000 MSM from 18 Latin American countries in early 2018. Please look for the LAMIS oral and poster presentations at this conference. Second, the IMPREP online survey, conducted as a formative component of the IMPREP demonstration study in Brazil, Mexico, and Peru, with responses from nearly 20,000 men, MSM. Please look for the IMPREP oral and poster presentations at IAS 2019 as well. Third, UNAIDS country reports, and fourth, data from HIV notification and behavioral surveillance from Brazil and Peru. Here, and in many other figures, I will compare two age groups, young MSM 18 to 24 and older MSM over 24 years old. This is the LAMIS online survey. With some variation across countries, the overall reported HIV prevalence was, say, 6.5 among young MSM and 20.5% among older MSM. However, when we look at reports of HIV diagnosis during the past 12 months, young and older MSM report similar figures, around 3% per year. This is a proxy for HIV incidence and is quite high. This is compelling information from HIV surveillance in Brazil. The upper left-hand figure shows the progression of annual HIV reporting by gender and age group between 2009 and 2017. One group O grows steadily across the decade, young males 18 to 24. When we look at transmission categories among those young males, to the right-hand side, 81% are classified as MSM. Now let's look at HIV reporting in Peru. The upper figures allow us to compare HIV reporting for two 5-year periods, 2008 to 12 and 2013 to 17. Cases reported among the 15 to 19 and 20 to 24 groups taken together went up from 3,500 to almost 6,000, that is 68% more between the two periods. Let's move to some The two bottom figures, actually, in this graph still, the two bottom figures portray the evolution over time of heterosexual and homosexual cases among males, clearly showing an increase in homosexual transmission, while heterosexual transmission remains stable. This change started to appear among the 15 to 24 group as early as 2018, that is about 11 years ago. The examples of Brazil and Peru are consistent with the regional pattern of a concentrated epidemic. About 2/3 of new HIV infections among 15 to 24-year-olds in 2016 took place among males. The right-hand figure shows that such trend is becoming bolder over time, and that the annual figures have continued to grow among young males while remaining relatively stable among females. About STIs now. Almost 9% of the 18 to 24 LAMIS participants reported having been diagnosed with either syphilis or chlamydia or gonorrhea over the past 12 months. This is clearly a high figure. Now let's review data on sexual behavior, access to care, and vulnerability. This figure about self-perceived HIV risks shows that despite the high HIV and STI rates observed, the majority of these men consider themselves to be at low risk. This other figure from LAMIS shows that about half of young MSM, as compared to 2/3 of older MSM, reported having been tested in the prior 12 months. This is an estimation of the HIV cascade for adolescents 12 to 17 in Peru as of 2017, as well as of the gaps to reach the 90-90-90 goals. Gaps are 17% to reach the 90% diagnosed, 15% to reach the 90% on treatment, but 42% to reach the 90% of viral suppression. In this figure from LAMIS, overall among young MSM who report an HIV diagnosis, 80% report having started ART, but only 64% report viral suppression, compared to 90% and 84% among older MSM respectively. For various reasons, levels of access to treatment, and especially viral suppression, are clearly lower among young MSM. What about sexual behavior? In Brazil, Guimarães and collaborators compared the younger groups of two samples of MSM from 2009 and 2016 respectively. Among young MSM, there was some progress. For example, less binge drinking, more HIV testing, and more access to information and services. However, unprotected receptive anal sex increased by 24%, illicit drug use by 22%, and low risk self-perception by 25%. Also from LAMIS, MSM of both groups report similar frequencies of condomless anal sex with non-steady partners of unknown serostatus, and of recent drug use to enhance sex. These data from the IMPREP online survey show that young MSM report more receptive and less insertive condomless anal sex than older MSM. This may reflect age-related changes in role preference or role negotiation, but also a power dynamics. Awareness about PrEP among young MSM ranged between 61% in Brazil and 37% in Peru. This may be explained in part by the existing PrEP policy in Brazil and by the proximity to PrEP information from the US to Mexico. In Peru and most other Latin American countries, the topic is still being introduced. These are figures for both PEP and PrEP use by age group. Despite the reportedly high behavioral risk, only 2.4% of young MSM and 5% of older MSM reported any PEP use in the past. This may be due to low availability and low awareness of non-occupational PEP. The figures are even worse for PrEP use, reported only by 0.6% of young MSM and 1.3% of older MSM. This means that access to both PEP and PrEP among Latin American MSM remains marginal, and this is very important. Willingness to use PrEP is similar across both age groups, between 50 and 60%. Often neglected, mental health is critical in discussing the experience of young MSM. In the LAMIS study, 62% of young MSM, compared to 54% of older MSM, reported symptoms of anxiety and/or depression in the past 2 weeks. Likewise, more young MSM than older MSM reported suicidal ideation in the past 2 weeks. Concerning use of alcohol and drugs in LAMIS, young MSM reported a slightly higher use of alcohol at 23% compared to 20% among older men. And likewise, the use of drugs in the past 2 months is similar across both age groups for most drugs. Now we will focus on social determinants of vulnerability. Let's consider the study of another young gay man. 21-year-old Marco works at a bank in the city of northern Mexico. As many gay friends, he's constantly checking Grindr and meeting new people. He uses condoms regularly, but the guys he meets are increasingly interested in barebacking. Recently, after giving up and having raw sex for the first time with a new guy he liked, he freaked out. He knew about PEP, but was too embarrassed to go to a clinic and ask for it. Fortunately, he came out negative, but now he fears it will happen again. He wants to try PrEP, but it's not available where he lives. Some of Marco's experiences illustrate the challenges that young MSM in Latin America face to remain HIV negative. At least he's not a minor. As in many countries, parental consent is required to access HIV-related services. While gay marriage has been legalized in Mexico and the legal framework is positive, he still feels that others are judgmental about homosexuality and is not comfortable talking to a provider about his private life. He also feels that clinics are odd and do not make people like him feel very well. Indeed, young MSM in the region are experiencing a world with many contradictory changes. The legal frameworks range from neutral to very positive, but it may seem that legal recognition has favored the mainstreaming of a commodified and superficial version of gay culture. Gay sexualities have changed as well, often adopting global trends such as new sexual meanings and new, more exciting but riskier sexual practices. The ongoing decay in condom use observed among MSM of all ages, however, is taking place in a context where larger gaps in HIV diagnosis, treatment, and viral suppression and marginal PrEP use are observed compared to high-income settings. The world today cannot be imagined without the internet. It has caused a radical transformation in communications, social interaction, and sexuality. Sex-related searches, online pornography, and apps remain among the most frequent motives of internet use to date. Its free and limited offer of all kinds of pornography is changing people's perception of sexual normalcy and promoting unrealistic expectations that especially young people may not be able to assess critically. The normalization of dating apps with geolocation facilitates hookups significantly, and is changing the way people meet their sex partners. Many people, in fact, develop a love-hate relationship with them and justify their use out of loneliness and boredom. A few even stop using them, claiming that these apps are really addictive. In one way or another, apps have become very popular in both age groups. Between 1/3 and 1/2 of MSM in the InPrep online survey indicated high use of these apps. In this radically changed environment, driven by new technology and the market, sex education policies are largely insufficient. In a context of unlimited access to sexual content and opportunities, policymakers continue to debate whether or not to offer sex education at school. Whatever sex education is currently offered, it is by no means sufficient to provide meaningful support to young people. It should be really completely rethought. Today's extremely polarized world hinders our ability to focus on balance. Fighting sexual oppression may give the impression that sexual freedom means no self-regulation. We may then end up measuring such sexual freedom by how much sex we have. We may then end up and equate it with success or happiness. Eventually, we might start feeling that we are being used or that we are using other people. We might then feel dehumanized. But likely we might continue with this because it adheres a strong social norm in gay culture in many settings and provides temporary relief for other problems. Young MSM who are learning to play the gay game will likely follow this path as long as there is no serious discussion about sexual lifestyles and choices within gay communities. And yes, it has to be an insider discussion, nothing imposed from the outside. But young people should be prompted to ask themselves why they have sex, what their personal sex needs are, and what they could do to ensure that their sex lives make them feel happier, more fulfilled, and more humane. Intervention strategies aimed at young MSM and Latin America are almost non-existent. Let's quickly review some of them. Ahora e Agora, The Time Is Now, was a demonstration project aimed at developing, implementing, and evaluating for feasibility a web-based intervention to promote HIV prevention, provide free anonymous HIV self-testing, and ensure linkage to care among those found positive. Led by Fiocruz and collaborators, this community-wide program took place in Curitiba, Brazil, between 2015 and 2017, including HIV self-testing kits to other online mobile testing units and testing in public facilities. The study showed that continuation and information technologies are promising in attracting young MSM who value anonymity and privacy, particularly those never tested and those at high risk who need frequent testing. Currently, I'm part of the InPrep consortium, implementing PrEP on MSM and trans women in Brazil, Mexico, and Peru. A sister project started in Brazil around the same time, led by University of Bahia, is called PrEP 1519, and focuses on young men 15 to 19 years old. This project incorporates a sophisticated communications component to appeal to young MSM. For example, they have created Amanda Selfie, an AI character who will guide young MSM through information appointments. Project implementation in Brazil has been delayed as conducting sexuality research with minors is still challenging in all the region. The formative study shows interesting information. Please visit the oral and poster presentation at this conference. Let's move on to Orgullo Plus, an ongoing clinical trial with MSM and trans women in Lima, Peru, testing a 3-year intervention with a community component and a health systems component that we are conducting in collaboration with UCSF. The community component, Generación Actual, is adapted from the Empowerment Project. Core elements involve a leadership group, a community center, mobilization activities, workshops, informal outreach, and a staff of 2 coordinators. The ongoing process evaluation has produced some early evidence of potential effectiveness. While the intervention is not limited to young MSM, we have observed a considerable increase in their participation. Such increase seems related to several reasons, not only including the many HIV-related resources that the program offers, but also factors related to increased opportunities and resources for personal development and well-being in a safe and welcoming social space. Finally, UNICEF conducted a pilot project focused on leadership training of 30 LGBT adolescents who were natural leaders in their regions in Brazil. The project had online presence through various social media and websites and conducted advocacy in various public spaces. The project achieved more visibility for this group, contributed to the public debate on sexual diversity, mediated the provision of peer support from the trained leaders to other adolescents, and overall bridged crucial gaps. Let me conclude with a few take-home messages. Today, we have gone through data indicating that there is a significant HIV problem among young MSM in our region, with HIV and STI incidences similar to older MSM, while ART coverage among those diagnosed, and especially viral suppression of the latter, are much lower than among older MSM. This alarming trend is, in the regional HIV epidemic is by no means recent. It has been going on silently for more than a decade, but we have failed to pay attention. Its immediate determinants include an increase in casual sexual activity in the context of a fall in condom use with minimal PrEP rollout and insufficient levels of viral suppression among positives. Drug use to enhance sexual activity is also common. Young MSM report practices similar to those of older MSM and in fact report more frequent mental health issues and also generally neglected. Key determinants of this problem include the legal and other structural barriers that minors and others face to access testing and sexual health services, a highly sexualized mainstream culture facilitated by the internet, a commodified, quickly changing gay sexuality, policies of sex education that are generally insufficient vis-a-vis the emerging sexual issues, the lack of visible, nurturing communities where young MSM could learn critically how to make informed decisions about their lives and sexualities, and limited appropriate interventions and programs for this group. In that context, we need a few critical things. First, we need to remove absurd legal barriers that minors face when they seek health care, always seeking the right balance between the protection of minors from abuse and recognition of their sexuality and autonomy. We also need to offer really meaningful sex education with content that can help the young in the current context. And definitely we should not restrict internet access. We know where it leads to. Rather, we should help young people develop skills to assess their own needs and decide. Then we should improve access to prevention and care services, doing as much as we can in the public settings to creatively reach young MSM with strategies such as those used in The Time Is Now and PrEP 15 to 19, for example. And we also need to recognize the natural limitations of the public sector and identify appropriate ways of working directly with communities and fund their work, possibly using approaches like those of Orgullo Plus and UNICEF. It is indeed crucial to avoid the takeover of commercial interests and the reduction of the community to a market segment. A community should nurture and educate the young. It should generate safe and balanced spaces for discussion of ideas where discrepancy is respected. The point is, how could sexuality contribute to happier, more fulfilling, more humane lives? Finally, we should recognize and celebrate differences, while at the same time identify and emphasize similarities, say, between young MSM and young men in general, or between young men and young women too. Young people do it all the time. Let's learn from them. This is Vayamos San Juan, a non-LGBT group, youth music group from a low-income area of Lima. They were fantastic in the recent local gay pride parade. Our world today is full of unnecessary conflicts that never get resolved. If we learn to work together more often, acknowledging that we are all human beings with similar needs and dreams, we could save a great deal of energy that could be used indeed in making everybody's lives happier, more fulfilling, and more humane. Muchas gracias.
The conference organisers would like to thank all the speakers and co-chairs for their participation. The plenary session is now over. We wish you all an excellent day at IAS 2019. As you leave the room, please remember to return your headsets at the door or give them to one of our volunteers. Thank you for your cooperation.